and the resident, is that echo now? Okay, and so the resident was, for me, was so respectful when he was speaking to her. Because he was like, push, 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 andale, andale, come on, you know, and it was just how he spoke to her. And she didn't understand what he was saying necessarily, but I know she felt the tone. And so, and no one said anything. No one like checked him. No one said to him that's inappropriate. And so when we are in these systems and we see things done and we don't say anything, then we're complicit. We're just as guilty as the provider who makes comments and says very disrespectful and very mean, you know, like these little microaggressions that people will have and do. We don't say anything about it, we're just as bad. All right. I determine what's right for my baby. When people decline certain things, they have thought about it. How many times have we, if you are a provider and the client says, no, I don't want these vaccinations. No, I don't want my son circumcised. No, I don't want, you know, whatever it is. And they get pushback. There's always like the next person comes to say, well, what about this? You sure you don't want that? And it's like this series of people to try to convince them of what they've already made a decision about. And what I try to tell other providers and nurses is for a woman who is, let's say she's in labor, she's GBS positive, she does not want antibiotics. And the nurse says, well, if something happens to that baby, then she'll blame us. I said, well, we found out at about 36 weeks, she was GBS positive. She was given the information to understand what the risk is, right? She is now 40 weeks here in labor. So she's had a whole month to think about that decision. She has probably Googled and TikToked and everything else to get all of the information she can about this decision. So she did not walk in here today and magically think, well, I don't want the antibiotics. Maybe what you can say is, well, what's your apprehension? Why don't you want this, right? So that you have an understanding of what she's thinking. And you can always go over the risk, but respect that they determine what they want for their baby, right? That's not my baby. It's not your baby. It's her baby. And if she's willing to assume the risk, you've given her the information, she's thought about it, then you accept it for what it is because she has the right to determine that, right? This is somebody, she's going home with this child. That child's not going home with you, right? My baby, my time. And this goes to that golden hour. Why do we take babies away from their moms and put them under the warmer and we have to do the assessment and we have to do all the checklist stuff, right? But what about the golden hour when that's when babies are transitioning? That's when there's learning to regulate themselves. My baby, my time. Like, let us start that bonding happening. There's plenty of time to do assessments. And guess what? We can even assess the baby on the mom, right? We want to get a temperature. Check the baby's temperature while the mom's holding her baby. You can check respirations while the mom's holding the baby. We can do all of that. But we don't have to take the babies, and I call it baby jail. We don't have to put the baby in baby jail. While, you know, when the mom just wants to have that uninterrupted time, and that baby needs that uninterrupted time, right? And so the other thing, the next one is listening to me. All right. So listen to me, listen to what I'm saying. People will tell you how they feel, they will talk to you, but you just have to listen, right? And believe me, that's the other thing. Why is it that we don't believe, if a person says, you know what, I don't think this is normal, this doesn't feel right to me, why do we not believe them? If they say to me, I'm having this pain, right? One of the things that I remember learning when I was in school some decades ago, and was so unbelievable to me to find out this is still being taught. Black women do not experience pain the same way that other women experience. Why do we learn that? Who came up with that? That's not true, right? Pain is subjective. What one person's pain, maybe somebody else, they're like, it's not that bad. But you have to believe people when they tell you this. If they say, you know, this is the worst headache I've ever had, we don't dismiss it. We say, well, let's see what's going on. If a person is having, you know, postpartum issues where they are hyper vigilant about what's happening with their baby, you might want to ask them, like, what's going on? Don't dismiss it as, oh, it's just your hormones. They may be suffering from postpartum anxiety or postpartum depression or postpartum OCD. We have those clients too, who have like this hypervigilance where they are having obsessive behavior, constantly looking at the baby to make sure the baby's breathing, right? But we don't address it because we're dismissing it. And that's what happens all the time. Recognizing my humanity, right? That is so key because sometimes we don't center people in their care and realize that even though I don't care how busy we are and how often we do the same thing all the time, right? We get caught up in like the system and checking all the checks and checking all the things and making sure we're moving through what we need to move through. But what happens is we wind up in the humanity of the client in the care, right? We don't know who they are. They become a number. They become a statistic. But we forgot about the human, the person in that. I mean, touch my computer. You have the right, you're right, respect me as a person. I choose how to nourish my child. If they decide they want to breastfeed, if they decide they want to formula feed, if they decide, whatever they decide, they want to get milk from the human milk bank, they decide, I don't want to do any of this. But we respect that because this is their child. Going back to what I said before, it's their baby. They're going home with this child, right? We encourage breastfeeding. We would love for people to breastfeed, but do we often give them the support they need to be successful at breastfeeding, right? Or if they are having that anxiety, we haven't addressed the anxiety. And so now they're caught into the thought of, I'm not feeding my baby enough. So we haven't addressed the mental health issue. We haven't addressed, you know, the support to give them, set them up for success. But at the end of the day, they get to choose how they're going to nourish their child. And I am informed. How many clients have you seen that have zero clue? They don't understand a thing because no one took the time to explain to them what's happening or just give them basic education, anticipatory guidance. This is what's going to happen next. This is what you look forward to before I see you at the next visit. Here are some warning signs and what these warning signs mean. Inform the patients. The way that our system is set up, we see people every 10 minutes in many offices. How are you getting through a visit and educating people and answering their questions in 10 minutes. It's just like, it's not sustainable. So people fall through the cracks, right? High-risk patients fall through those cracks. Your diabetic patients are not getting the full education, and then you wonder why their blood sugar is out of control because no one really explained to them how they should be properly eating, what their diet really should look like. My pain matters, right? Going back to listening to them. And I'm held. When I talk about being held, it's like that the resources that are out there are holding their space for them. That they know that somebody is really caring about what's gonna happen. That their provider is holding space for them. Their doula is holding space for them. Their community health worker is holding space for them. Their family, a support system, whoever is there, they're held. They're holding them down. And it's a safe place for them. Too many of our clients don't have a safe space, right? So if at home is not safe, because it's a very toxic environment, they come into the office and they're dismissed. Who's checking for them? Who's holding them down? When they show up to the hospital and they become like a part of the process, are they being held down there either? Right? But everybody has the right to be held. My mental health matters. I think that's self-explanatory. I have the right to say no. If something, when people come into our care and they are not comfortable, they have every right to say, please do not do that, and not be labeled as a difficult patient. How many times, this is one thing that always makes me very cringy. When you work in the hospital, like when people come in through labor and delivery and a client does not want to get checked. They don't feel comfortable with that, you know, or get checked as often. You know, I understand getting a baseline check. Hey, I need to know where you are. What can we do so that I know if you're in active labor, where we're starting from? You know, I feel like you can negotiate, and many times people will be like, okay, you're giving me a reason, this makes sense, yes. But they may not want to get checked every 2 hours so that we're checking this box. They may not want that to check progress that way. They may not want to have, you know, people, a whole slew of people in their room. Maybe they want to just have their provider come, their nurse, their support people, but not the team that comes in and teaching hospitals, right? You ever think, I mean, I've been there, I was an attending, and it was like, okay, so how can we limit how many people show up in this person's room? And it's overwhelming, especially when you have a birth and let's say the baby needs, we tell people, listen, we may need the team to come in here to see about your baby. So the NICU team or the respiratory or whatever team it is, there's gonna be about 3 people. Let them know, because we may need them in here. But then they come and then there's like a whole other 5, 10 people and you're like, why are all of these people in this room? This lady is up here, all of her parts are like out, she's uncovered, she's naked, she's whatever. And it's like, one, their humanity has now been stripped because they're exposed to all of these strangers. And they say, well, I don't want that. And we're like, well, why not? Well, what's the problem? Well, why are you being so difficult? You know, think about how would you feel if you were in that position with, you know, and people are asking you things that you're not comfortable with. Also think about clients that may have trauma, right? A lot of times we're just meeting them for the first time in the hospital, right? But we don't know what trauma they have been through where being touched is a problem. My intersecting identities are respected. What do I mean by that? The intersecting identities, right? So we're talking about Black birth and people, but what if they're queer, right? What if they have some type of disability? What if they, whatever it is, that these are different identities that they have that also need to be respected. I mean, another identity is active duty. They're an active duty member, right? They're in the military with special needs that go with being in the military. You know, all of those things should be respected. Please include the partner. If they have a partner, do not act like they are not a part of what's going on. Because one of the biggest complaints that I get from partners is, I didn't know what to do. I didn't know how to be involved. And they feel like they're in the way because they're made to feel as if they are in the way. Include them in the conversation. Albeit, this is my, like, she's or they are my patient, but they didn't create this baby by themselves. So if there is a partner, include them in what's being done. Queer and trans identities are acknowledged and respected. Use the right pronouns, please. Respect that. I cannot emphasize that enough. Please respect people's pronouns and their identity. I don't care if that person is fully bearded and they want to chest feed and they are John instead of Jane. They have given birth or they are giving birth to a child. They are a man that is giving birth. Respect that identity. It goes a long way to say, how do you want to be, you know, what do you want me to call you? Are you gonna be dad? Are you gonna be a parent? What is it that we're gonna use? And respect that. Ask people. Everybody doesn't subscribe to, you know, they may not even say I'm a he or him, she or her, they, whatever, Z, they, and all these pronouns, right? But just respect it. If that person introduces themselves to you one way, then that's what they are, and you just respect that. I feel like at the end of the day, what you eat does not make me poop, right? And I cannot make decisions about how you live your life. I know how I live my life, but I'm gonna respect how you live yours. My body is honored. Heavier body people, people with differences, say disabilities, things like that, honor that. I cannot tell you how many times I've had people who are overweight, obese, heavier bodied, and they're like, oh, you can't put on this weight. You need to, it's like, you know, almost making them feel like as soon as they walk in the door, they're gonna have an unhealthy pregnancy because of their weight. And it's like this fat shaming that will happen. Don't do that. Don't do it. You meet people where they are. You know, I can say I've had very healthy pregnancies of women who were 300 plus pounds. The baby was fine, the mama was fine. They didn't have any extra things. It's a risk factor, true. But if you work with people and they are motivated to stay healthy, they'll stay healthy. They'll do it because they really are motivated to have a healthy pregnancy. But if you shame them, then that's not gonna happen. I choose how to become a parent. Everybody is not going to have a pregnancy the old-fashioned way. We have IVF, we have adoption, we have surrogacy, all of those things, people have the right to become how they want to become a parent. So now, in all of those rights that we talked about, what are gonna be challenges? I'm gonna ask you in the audience, what are challenges to making sure that people have these rights?
Making the public aware of those rights.
So public awareness, language barriers, lack of education or access, right? All of those things, right? We have institutional racism. right? Implicit bias, underrepresentation in healthcare. So one of the things that I will say, even me, the Black midwife, I have my own bias because we all have bias. We all, I mean, it's just how you, whatever way you're raised or whatever, but we have to look at ourselves and examine ourselves and say, okay, what are some of my biases and how do I address them, right? If I was raised in a very conservative Christian church, I was raised that way, I may not understand somebody who comes through the door that is transgender, because that wasn't how I was raised, right? Or queer. But if that's my bias, then what I need to do is say, okay, how do I check that at the door and still provide the care for this person that's gonna be very objective and inclusive? And if I can't do that, then I should be able to admit that to myself as well and pass that care to one other provider that can give that person the care that they deserve. And I'll say this, it's okay. It really is okay. We don't have to just get through the day. If you feel like you're not able to give that care to someone, then don't do it. You'll cause more harm than anything else. But admitting that you have a bias, you know, and so even when I'm reading in the news, it's like this doctor now, they can refuse care for this group of people or whatever. You know what? I support it, honestly. I'm one who supports it because I would not want to walk into any practice and they look at me and they, before even meeting me, listening to me, have already sized me up and have decided who I am. And they're not gonna give me the care that I feel I deserve. I would rather go somewhere else or have them pass me off to someone and say, maybe I'm not the provider for you. So the question is, what can you do, right? So as a healthcare professional, consumer or policymaker, what is it that we can do? Okay, in this room, how many of you are healthcare professionals? Right? Okay, how many are just consumers? Right, consumers, right? We're all consumers. All right, anyone in like administration or an ability to, right, organizational kind of stuff. Like, what is it that we can do as a healthcare professional? How can we make our care more inclusive? What is it that we can do as professionals?
I'm sorry.
It was mine.
We can increase our knowledge and education and work on our own biases.
Absolutely.
What I was gonna say, from one of my dear friends who is now retired, but she is a certified nurse midwife. And she's delivered, well, I think over 4,000 babies. But from what I learned from Dr. Atkins, Marcia, was that she tells her prospective patients up front, this is how I operate and what I expect. You don't do, that is my baby right now. I am taking care of you for the next 9 months. And if you can't abide by my rules and regulations to make sure that you have a safe and healthy baby, then maybe I may not be the provider that you want. So she tells patients up front. And so either they love her or they, Dr. Atkins, she just told me such and such, but that's okay. And anytime someone has over 4,000 deliveries with no complications or very little, I think that's pretty good, I think. And that's because I'm biased, because she's my friend.
Maybe she's honest up front, right?
I think what we need to do is we need to actively listen to people and meet them where they're at. Talk to them in a language that they understand and build that rapport with them from the very beginning that they know that no matter what they say, they will be heard.
Another one. I think that a lot of, issues stem from a us and them mentality. And we need to recognize that it's no us and them. We all know someone or can relate to someone or have someone in our lives, or it's us ourselves that have had similar experiences. We're all one. And so sometimes when you get that us and them mentality and that power differential, that's when those issues come up, instead of having just like a holistic view, you know?
I would say increase advocacy to promote better maternal health equity. Coming from the equity specialist herself. I take my job very personal in serving my community. So I do advocate and I'm outspoken. I speak up in rooms where it's like, hush, don't say that, you represent PDH, but my community, my people. So just having that, which goes hand in hand with educating ourselves, and so we know what to advocate for and what to lobby for and what bills, you know, needs to be passed and what needs to be spoken of, but definitely advocacy.
I think that under representation, I think, you know, just putting ourselves in the places and spaces to where we can be the person that people are looking for. Because at the end of the day, for there to be a doctor and midwife that looks like you, that takes us doing the work to become that doctor and midwife that looks like you. And I think, you know, just being able to tell the youth and the generations that are coming up, just, you know, how important it is to be in certain spaces. You know, you don't have to always run to being in the entertainment industry. There's so many other ways we can provide support to our community so that, you know, we're just providing better for the generations to come.
I have a question. So statistically speaking, Black people represent 13% of the population. What percentage do you believe, or do you know, are, like, in terms of the population of midwives that are out there, what's the percentage of, say, Black midwives?
Well, that's not 2%.
Well, it's less than 5%.
Less than 5% that are out there. And so, and then there are different pathways to midwifery, right? And so that's another thing that we talk about when we talk about the right to choose. Like, you should be able to choose your healthcare professional. So what if someone has a traditional midwife that isn't licensed in Virginia, but they have chosen the traditional pathway, or they have a nurse midwife or a certified midwife or a certified professional midwife, and they make that choice? Whose choice is it? Right? It's the client's choice. And I can say, like, I've heard people say, well, what, they got a midwife, which kind? Is it one of them lay midwives? And I'm like, that's so disrespectful, you know? Like, just, if they made the choice, they vetted that person and that's who they wanted. Right? Just like, you know, everybody doesn't feel like they should have a physician as their provider, or even what type of physician, because OBs do deliveries, family medicine doctors do deliveries. Do we frown upon people who choose a family medicine doctor to do their delivery? You know? Right.
I guess my question would be, when it comes to all the different types of providers you can choose, like, how, as providers, like, how do we create more baseline so certain professions aren't looked down at, so to speak? Like, is that just more so an education piece, or that's just up to the people that choose to use us for their services? Or like, how did that come about on a national or a greater scale of when it comes, you know, because like you said, people look at, oh, you went to nursing school, so you must be a better midwife than somebody that didn't go to nursing school, you know? So I guess I'm just trying to understand, like, how do we break down those barriers when it even comes to that?
Okay, so I'm just gonna say this, and this is probably not the popular thing to say, but just because I went to nursing school to become a midwife does not make me a good midwife. Just because a person is a nurse before becoming a midwife It just made them a really good nurse. It did not make them a good midwife. It was an extra set of skills that they may have brought with them into midwifery, but when I'm practicing as a midwife, I'm practicing midwifery. I'm not practicing nursing. And I always liken it to say that a nurse midwife is two different disciplines, as if I was a nurse who also happened to go to law school. You never say a nurse attorney, right? You don't put them together. Very two different disciplines. But I think that we in our OB/GYN community need to have more cohesive relationships. We need to partner more. We need to understand who's who in the zoo, know who is out here in our area practicing. And that helps with, like, there are some states that are better than others, some communities that are better than others. My big dream in life is to have a smooth transitions type model in this area. If we can master that in the 7 cities, then we can definitely move it on to the rest of Virginia, where we have good transfer protocols, where we have good relationships from community into the system, from the system into the community. So that when I have a client who is not safe for a home birth, and I'll say, after 15 years, I came into the community, I do home birth now. I don't do hospital births anymore. Will I go back into the hospital? Absolutely, I would get privileges to have continuity of care for my clients. But if I have to transfer them in, I want to know that there's a nice transition. I can call the OB or the midwife or whoever is on and say, hey, I have such and such and such and such. This is what's going on. I'm transferring them into you. Send their records. The person who's receiving them knows they have records. They know what's going on. And it's a nice, smooth transition. Unfortunately, we don't have that in our area. We don't have it in our community. And even when they're still pregnant, if I have someone who, now we got a risk here, and we need to have some type of collaboration with a provider that can offer the services that they need so that they can be safe. Sometimes we don't have that. Now, I will say, EVMS, EVMS, I work with them. I send my clients to them and I've had good relations. I can't say that every midwife has also had that is in the community, but I've had really good relationships with the providers that I've spoken to. But I've also had some really not good phone conversations when we had to transfer. So it's kind of hit or miss, but
I'm curious to know if you know of a state or a community that is progressive in that way.
Washington has transfer protocols, Oregon, New York State, they all have statewide protocols that they use. And what I mentioned was smooth transitions. So smooth transitions is a model that is in Oregon or Washington, I can't remember off the top of my head, but it's something that's done. And they even had some years ago a home birth summit where every stakeholder came and met. You had maternal fetal medicine, obstetricians, midwives, all types of midwives. You had EMTs, right? So you had your emergency services, the neonatologists, the pediatric providers. Anybody who was a stakeholder came together and said, okay, what can we do to have good outcomes in our area? How can we move people in to navigate these systems, right? And what came of it was everybody brought their lens. I, the midwife, have this lens, right? But your neonatologists are gonna look at things a little bit differently. Pediatricians are gonna look at things differently. EMTs are gonna look at things differently, right? Because they get a certain type of training. We all get a different way that we look at the situation. You think mom and baby, right? I'm looking at mom and baby, my OB, colleague is looking at the mom because the baby's out, because they don't even deal with the babies. The pediatrician is thinking about the baby, not thinking about the mom and what's happening with her. EMTs, like, they don't want to deal with it at all because they're scared, but they're like, we're gonna get through this, you know? So everybody has a different lens and a different approach. But wouldn't it be nice if we all sat together and said, okay, how are we going to make this work? How are we going to fix this? What do you need in order for you to be able to do your job effectively? What do you need in order for you to do your job effectively? And how can we all work together and come up with agreements? And that was done some years ago. Unfortunately, like, we need that in Virginia. If y'all are listening, we can sign up, we can do it, right? But these are things that we can do in order for us to turn the tide and include our clients in their care. Also, have better outcomes, right? So resources, I'm just gonna put these out here. These are some people who are doing the work. The Black Mamas Matter Alliance, that is a collective of several different organizations that have signed on to work with Black Mamas Matter. The National Black Midwives Alliance, little plug for that. I am the board chair. The National Association for the Advancement of Black Birth, the National Birth Equity Initiative, Sister Song does a lot of reproductive justice work, and also the Southern Birth Justice Network. All right, questions? Any questions for me?
Can you go back to that?
Oh, I'm sorry. Yeah, I'll put this up there, but any questions at all?
I was gonna speak up for the folks online. We just have three. One
Okay.
of them is named Justice. And Sherry has said, speak, and given some clapping emojis.
Hey, Justice.
I've asked if they have any questions, but nothing so far.
Okay. Yes.
Really going back to what can we do as healthcare providers. I remember being in labor, this a long time ago, but labor and delivery, and for whatever reason, my colleagues and everything, had a mother that was in labor. We knew her and everything. And she had just been off of a medication because she was schizophrenic. And for whatever reason, nobody wanted to really take her, and they were like, oh, give her Rousing. Rousing's really good with patients like that. And I'm like, what are they talking about? And then I walk in and see that it's the patient that I'm familiar with. And basically, her name was Eleanor. She said, I said, when you're having your contractions, in between the contraction, I asked her, what do you want me to do for you? So she told me. She's very well put together, her makeup. She said, I want you to go and get a mirror and get a washcloth, dry washcloth. And I said, oh, okay. So when it got, so between her contractions, because she had a full makeup on and everything, and her hair was all nice, I had to make sure to dab her forehead and put the mirror in so she could see that her makeup was still good. And if we were talking, and if I missed the beat, I'm finished with my contract, she just looked at me, and I was like, oh, I'm sorry, Eleanor, okay, here, and I put the mirror in, she says, okay. And she said, you gotta dab my forehead, and that's what I did. And she had a wonderful delivery. I had no problem, but it was the idea that my colleagues didn't want to have to deal with her.
Cause they just already had bias. They didn't even know that she was gonna be fine. I mean, I'm not gonna lie, I had one of my clients, I had a lady who had she was paranoid schizophrenic. So she tells me this, and immediately I was like, oh my gosh, am I safe? Is this gonna be all right? What's going on? And she wound up being the best patient ever. She was amazing.
Yeah.
During the entire time
Yep.
that she had, you know, during her prenatal course. But it's still like the unknown, and you're like, I don't know, cause they might do this or they might do that.
So they put, and it was just her and I in the room. There was not an issue, and she was a very good mother. She brought the baby up later on, all dressed and everything. The baby looked immaculate, you know, they all looked, she looked immaculate, and baby did too. So you would never know she was schizophrenic until she started tell you some stories.
Yeah.
Then you knew something was not quite
Then
right.
you'd be like, did you take out, are you on your meds? What's going on?
Yeah, I said, oh, you back on your med?
Yeah, I'm back on my bed thing. I said, okay.
My bipolar, they get pregnant, bipolar people.
Yeah.
They get manic,
No,
they get
tell
pregnant.
everybody, they get pregnant too. There you go.
Right, well, that's my contact information. If there are no more questions, it was my pleasure and I thank you all. And hopefully you learned something.